Hello and welcome to the Vet Rap podcast. I'm here today with Dr. Clara, who is she is our only emergency registrar, emergency medicine registrar. She does her exams year after next. And we're here today to talk about a emergency and surgical topic, which is gastric dilatation-Volvulus. I'm going to start with your bit, which is your Great Dane comes in into the hospital and has been retching and non-productively. You know the story. I think we can reach beyond the point of diagnosis of we may not. Should we talk about diagnosis of GDV just right from the outset?
Yeah, and I mean, I think even in ECC, it's a tricky one because you get the phone call saying my dog's retching or sometimes even coughing or has had a vomit. And it's, well, what breed is it? Is kind of one of our first things. And if it's a large breed dog that's deep chested, we're immediately thinking GDV. Now, what's interesting about that is we know from the literature, is there a predisposition? Is there enough evidence to say that, yes, a large breed is definitely going to have this, but it's certainly something that kind of tweaks in our minds straight away. Large breed dog, retching, non-productively, I'm prepping for a GDV.
Yes.
100%. Yeah.
And then when the dog comes in, you are reaching for the radiograph straight away? Is that your typically?
Well, I actually reach for the fentanyl straight away. Because inevitably these dogs they're painful, first of all, and we're then having to put them onto a table because we don't have our lateral beam or whatever it is, the standing beam. So I'm getting fentanyl straight away. I'm getting an IV in them, fentanyl, because whatever happens, if, we end up putting the dog to sleep, for example, we're still going to need an IV anyway. So for me, IV, once I get my IV in, I'll pop a little 1 ml syringe on, get enough blood to do a lactate. If you've got blood gas radiometer, perfect. PCV-TP, perfect. Fentanyl, nice and comfy. Straight away, a right lateral X-ray. And then I can go from there.
Yes. And you're looking for that double bubble sign, as they call it? Or?
Double bubble, but it's one of those things. I will preface this by saying I absolutely hate GDVs. I hate them. I
thought that's what you guys dreamed of. That's
No. Can't stand them. But
give me a snake bite every day.
Oh, every day, a critical case. Anyway.
Yes.
But yeah, so the double bubble is great when it's there. But there are some times when you're like, is it? Isn't it? And I think that's tricky as well, especially if you're someone who doesn't work in emergency, if you're in GP and maybe you see GDVs less commonly. You look up GDV X-ray and it is that double bubble or like the Smurf hat.
Yes.
They are not always like that. Nope. And you can be really, really thrown. And sometimes it's just a GD and it hasn't V'd yet. And those ones are tricky as well. But for me, what I kind of say is, the animal is still presenting a certain way, so we're still going to do what we want to do with it.
And I mean, I guess on diagnosis, when they say we're comfortable with our radiograph and we're pretty sure that's what we've got, I think the key discussion point about GDV has to be, what are we doing in terms of stabilization? For how long are we stabilizing? And can we give an owner an idea of prognosis before we commit to surgery and come out the other side? So I think we should probably try and cover those issues in one question, which is how do you stabilize the dog? For how long do you stabilize the dog? And what prognosis can you give? That's one question.
Oh, no. 2026 was my exam year. Well, I guess the biggest thing is, and we're actually really, really lucky because we have quite a few papers recently. And what we'll do is we will screenshot all the papers we're talking about and pop them up so you guys can have a look. And the papers are basically telling us that even though it's scary and yes, something's twisted and you're worried about devitalization of the gastric tissue itself and then whatever other organs might be involved, you can actually stabilize them. You can take a little bit of time with the caveat that you need to really use your lactate as a bit of a guide. So for me, after I have the fentanyl in, my stabilization is attempting decompression and fluids to try and get that lactate down. Now, decompression, again, it's a bit controversial, I guess, in ECC sometimes. I'm definitely a person, my dog has had fentanyl, they're usually quite flat. I will try and stomach tube them. My top thing is I put a large vet wrap in the mouth like this, so that they don't then bite down on my tube, and then that's a foreign body in their GDV. So I put my stomach tube down, lube it. One of the reasons why I really, really like doing that, it's twofold. First of all, I'm compressing quite quickly, but also I'm not contaminating anything. So when I'm going to be going into surgery, I haven't kind of poked loads of holes in a stomach. So I quite like doing it. However, it can be stressful for some dogs. Some dogs just don't cope, and you don't want to be stressing them out when they're already cardiovascularly stable. And also there has been some cases where the twist has been so bad, I haven't actually been able to get the stomach tube down into the stomach. So that's when I'm trocherizing it, and I'm getting my IV catheters and I'm just popping them in. The biggest tip, or I guess thing to think about when you're doing that though, is you've got a twist. In that moment, we don't know where our spleen is sitting. So you really are flicking the stomach, hearing that moan, that like really loud, exactly, hearing that tympany, and you know that in that exact area, there's no spleen there. If you can't find an area that's like that, I just wouldn't, because you just don't want to poke a spleen.
And having personal experience of doing that, and then having the sort of the aftermath of that was actually a dog whose the spleen was bleeding at surgery, but just a little tear. And I left that. I thought, well, that will clot, I'm sure. You know, laparoscopically that happens, and it does eventually clot. And of course, there's so many things happening in a GDV. You know, the clotting parameters could have been all over the park, and may not have been able to clot. And we watched that dog for about 3 days, wondering whether it needed transfusion. I was like, I should have just taken the spleen out. Absolutely.
And he was fine.
He was fine. He was fine in the end. It was just this kind of PCVTP kind of doing this, and a constant diffusion. And
it's just the worst.
So it does happen. And my retrospective advice would be, if that does happen, frankly, I would just make the decision to take the spleen out,
because otherwise it's 3 days that you're sitting worrying, watching the dog.
And I might not have gone away with that. And you have to consider that dog does have clotting issues when it gets sursy and
yes, they're so pro-inflammatory. 100%. It's
just a slight aside there.
It's a good point. It's definitely a good point. And I guess, I mean, once I've done all those things, say if I've got a lactate initially starting at 12 and I've decompressed, I've given fentanyl, I've given a fluid bolus, if my lactate comes down to 8 or 9, my animal is still cardiovascularly not great, so still a little bit hypotensive, maybe a bit tachycardic, I actually at that point will probably try and stabilize further rather than saying this is as good as I'm going to get rushed into surgery. And I think that's a big change in our industry. And we have the literature out there to show that you can do that.
There are papers. I mean, there's papers, like always, papers will prove one or both things on controversial both ways. There's an Australian paper that kind of suggests that operating within 2-3 hours improves the outcome. Also, being operated on by a specialist to improve the outcome in that paper as well. Not that I'm advocating getting up at 4 o'clock in the morning.
I was going to say, I'm happy for them to call you instead of me in the future.
I'm not going to push that point. But then there are a couple of papers from Europe that are literally one paper, Davis White, their average operating time was 22 hours after presentation. And that was the outcomes, there was a 9% mortality on that paper, I think. And that is a really good outcome. And they were taking the time to stabilize and was sort of showing, and we'll come to prognosis, we're sort of coming to it, because it was in part of the first question as well. But you have talked about lactate a little bit. And whereas lactate was taken as, if it's over 6, and the sensitivity and specificity of those tests is not always as you'd like it. But that paper, Davis White was talking about reduction in lactate on treatment is a really good prognostic indicator. Not necessarily just high on presentation.
Which I think is quite important, isn't it? Because lactate can be high for so many reasons as well. And yes, a high lactate, it's scary. And definitely from ECC perspective, I'm telling my owner, look, this isn't looking good. But I'm definitely more comfortable now to say, look, this is a very scary level. This is not looking good. We may not be successful here, but let's try and then let's reassess. Rather than kind of being like, ooh, I just don't think we should even go ahead.
Yes.
But it's that kind of point of, we don't have to any longer, especially even in GP, if you're, a vet on your own and one nurse by yourself and you've already got a crazy busy day, you can stabilize that GDV and then send it on the way and know that that's actually okay.
That's okay.
You don't have to kind of say, I now need to put myself and my team under pressure to jump into a GDV. If you have that lactate and it is responsive, then you can just say, it's fine.
Especially if you can get a nasogastric tube into it.
Yes, yeah. And that's something that I've done a couple of times as well with just GDs to kind of stop them rebloating. But also in certain circumstances where people have come to me in emergency, I'm giving them quite a big estimate to, save their dog's life for the initial stabilization and the surgery, and they're telling me I can only afford to stabilize and I can't afford surgery. I'm saying, okay, I'm going to put an NG tube in and I'm going to continually get that air off of your dog's stomach so that we can get him to your GP vet tomorrow, because they'll be able to do as good a job as me in the surgery, and he's got the benefit of fluids and stabilizing overnight. It's a game changer, absolute game changer. It's tricky when they can't get past, but even with a really, really big twist, the stomach tubes, that the size of them, the 8 Frenches, they're so small, it would be rare to not be able to put it the whole way through. So definitely stomach tubing, and there's papers out there that show it's effective as well. It's absolute game changer.
It does take the pressure off.
100%. And I mean, not just for me overnight in the GP setting. Okay, you've stabilized, you've decompressed, but maybe you're in rural and they've got a 2-3 hour drive. Popping it in so that then when the dog gets to me, we just quickly take out what we need to, and then it's done. It's so handy.
And that's okay. I mean, we, as Clara says, we will throw the papers up there so you can have a read if you like. But there is plenty of evidence to suggest that so long as you can decompress, and I think that is probably the key point. Obviously, there are going to be cases where you're struggling to pass the stomach tube. Maybe you've managed to put a couple of needles in or whatever. You've got some decompression and there's some improvement, but it hasn't gone all the way, and you feel like you're going to be forced into surgery sooner rather than later. And those papers had those groups, or certainly one of them had that group in there, sort of 4 or 5, I think, out of 20, 30 patients. They just couldn't. And they went straight to surgery, and that was just a different group of patients.
Yeah. But I think, again, that goes to, the whole point you made about the lactate as well. Like, just looking at the individual. The individual, how are they responding? What are they telling me they need? And then going with that rather than saying lactate is this, therefore this is the only thing it can possibly be. I think we've definitely got that leeway now, especially for people like me who want to avoid cutting them at all times. So then I do have a question for you, actually. And it happens me all the time when the guys will call me and I'll be FaceTiming in the middle of the night. And they'll be asking my opinion on whether I need to take out a bit of blackened stomach. And I always find it really, really hard to make that decision myself. So usually over FaceTime, I'm like, I'll just come in and, I'm like, I faff around for ages trying to figure out, is there is there a better way for me to figure that out?
I mean, there's lots of literature on this element and whether or not this gut is viable at time of surgery, and obviously at 2 o'clock in the morning, you're not necessarily going to get fluorescein out and play around with that. I guess 2 or 3 things. One, I would say, how aggressive you are depends a lot on how confident you are about, closing that. And it's like any wound. I think it's certainly my experience that I've had cases where they've become more necrotic after 2 or 3 days. So what you choose to take then, you've got to accept that you may well have to take more later. So I think, first of all, whatever decision you make, it is probably not the reason that dog's going to fail. One way or the other. I think that there is a risk that you're going to end up having to take more, even if you took it then. Secondly, I think if you've got staplers, my goodness, they make a difference. Those things.
I do, but I've never used your fancy staplers.
it just speeds up the process like
can
you would
imagine.
not believe. And
Yeah.
and I, it's one of those things. I think increasingly that sort of technology will become available for people. Things can be ethylene oxide sterilized or hydrogen oxide sterilized. And you can do it, and it learning to use staples makes a difference if you're seeing enough cases to make it worthwhile. But to answer your question, I'm not sure there is any magic in the moment. I think, sure, you can just make little cuts and go, well, there's no bleeding happening at all there. It's a very basic, probably not very sensitive test, but it gives you a pretty good indication if you're already thinking that's.
And what's this fluorescent? You threw fluorescent out there. What you're putting fluorescent on the stomach?
You can inject it, and it under UV light, it will actually, if there's no fluorescent getting into the site, then it's a very sensitive way to get it.
Right.
I don't think you're going to be doing that.
Probably not. But that's so cool.
There's lots. I mean, there's lots of ways. That's an exam question.
Yeah. Oh, okay. I understand.
It's one of those.
How quickly take notes.
There's a lot of ways you can assess, but it's obviously in small intestinal end to end, and that how do you test for viability? It's challenging,
Yeah.
And I think. I mean, we obviously have this sort of policy at the ORH that it's okay to say, look, I'm going to take this, but I might have to have a second look. I think one of the things on the papers, one paper could prove nothing, sort of thing. But the paper that was talking about surgeons, specialists, and GPs. There was also a time thing. Like the longer it took in surgery, those patients were more likely not to have a successful outcome. Now, that could be cause and effect, obviously, because they might be taking a long time because they're having a lot of gut cut out or fundus cut out, and that might be the effect. But at the same time, spending a long time on decision making might be better off just getting it, PEXI derotated.
Yeah.
And going, well, it looks dodgy, but for now, that's enough.
Yeah,
because it pays back to that thing we were talking about if you can decompress, you've got time before you do surgery. If you can decompress in surgery because you needed to and PEXI it, you've got time before you make any other decisions. As well.
Yeah,
to some extent.
Yeah. And I think it's
I mean, that's not
true.
in the papers, but it sounds logical to me.
No, I agree completely. And I think that one of the things that I've learned massively, and it's really helped me with my decision making. So when I do get that call at 2:00 on FaceTime, I'm actually happier sometimes to not come in and to give the recommendation of exactly what you've said. If we need to go back in, we can go back in. Just leave it and see how it goes. And that's that I learned from yourself and Arthur with, our enterotomies and end-to-ends when I'd be looking at pieces of gut and thinking this is never going to survive, and you guys are like, just see. Worst case scenario, we just go back in a couple of days.
I think it is probably true to say that the stomach can look really bad but still recover. That I think that in general it probably looks worse than it will ultimately be. I think probably. And I mean, decision to take the spleen is also, if it's hemorrhaging or if it's, I think that makes its own decision to some extent. But no, I think probably the advice holistically across the fundus would be, well, if you're borderline about it, I'd probably leave it and move on. And what I wouldn't do is spend an hour and a half wondering.
Because then, it's an hour and a half. No, it's absolutely fair. And so then, do you have any tips for me as far as, so I do incisional gastropexy. The reason why I hated GDV is because of the incisional gastropexy. I feel like in that moment, I like to say I'm quite coordinated. I did Irish dancing when I was younger. So I do
that's your feet. Your legs. I don't think your hands do anything.
Look, they're down like this. But I find it so cumbersome and awkward.
I think it is.
I find like I'm inside in the animal's abdomen. So there's no easy way. There's no like...
At 2:00 in the morning, if you've got an assistant, that really helps. So, I mean, it really helps. Like just to do that.
So the assistant is holding this part back.
I mean, I think if you don't have an assistant, but you do have a nurse who's not scrubbed in, to speed up the process, to grab some long retractors or even towel clamps or something that you can just hook into the muscle and just pull back.
It's
not exactly ideally sterile, but I think again, it's if you're fiddling for 3/4 of an hour on a surgery that, let's face it, you're making a cut and you're stitching.
Yeah.
And the only challenging thing about that is because you're feeling like you're trying to jump into the dog to do it.
You're like,
otherwise
all the way
it's
down,
easy. Like, I mean, certainly I think it's now fairly accepted that although the textbooks will talk about the belt loop and all the rest of it, that all of those things are really probably unnecessary. So we really are talking about an incisional. And so you literally are just making a cut through sclerosa and some muscle there and here on the peritoneum, and you are just suturing that. So just to have someone to do that is kind of really the only tip, I guess, I've got. Yeah. What I would say is do it on the right side of the dog.
What do you mean?
Okay, unfortunately, we have seen the occasional left-sided gastropexy, and unfortunately, we've seen them because they've torsed.
Yeah.
So,
and it's one of those things, isn't it? You kind of look at a case like that, and if a left-sided gastropexy was to come to me, I would be thinking, oh my gosh, I reckon this was someone under so much pressure that, and probably getting asked 10 million different things in the background and just trying to do the best they could. And that really goes back to that first point of, we know now you don't need to do that. You don't need to put yourself in that position now. You can actually say, I actually do not have the capacity to do this, or I'm not comfortable doing this. Let's just focus on stabilizing, so that you don't do it on the left.
Yes. Well, it definitely happens.
So then, are we at that phase now in the industry? Is there evidence out there? Should we be doing it where in GP, in ECC, when I'm seeing these dogs as puppies, am I starting that conversation with the owner now for prevention? How are we preventing it?
I think we definitely are.
Yeah.
Now with the sort of at-risk breeds, and especially with some family history, those dogs should be immediately a discussion for gastropexy, and I think the advent of laparoscopic gastropexy means that maybe the decision doesn't have to be tied directly into desexing. Like it was always a desexing gastropexy, whereas desexing the large breed dogs now be something that is more of a decision, and you can, that's a very large podcast that we may cover at some point in the future. But the taking away that element of, because a gastropexy, like you've already said, is quite an aggressive surgery. Like you cannot, especially if you are combining it with a spay, it's like here and also there, and let's join the dots and make it there. A laparoscopic gastropexy, especially genuinely laparoscopic, so not laparoscopic assisted, which is where you kind of use the laparoscope to grab hold of a bit of, or find a bit of stomach you like the look of, and then come in from the side and grab it and pull that towards the body wall and then cut down onto it. Through the sort of the mesh sort of cut through there. That's okay, and I've done that for quite a long time. But it does, I think it has a complication. I don't think those wounds always heal very well. I think they're quite sore, that area post-operatively. Since we've swapped to entirely laparoscopic gastropexy, which is essentially suturing internally, which is fiddly, requires a little bit of kit, but it's such a nice procedure. Like it is genuinely, a couple of small incisions and you're done. Yeah. And I think it's then a much more palatable thing for an owner to decide to do.
Especially if they're not having to desex, breeders, show dogs, people who, the larger breeds that we don't want to desex them too early, but then you don't want to make sure they don't get a GDV either. Yes. So is there, if you're doing it lap-wise, do they have to be a certain age then? Is it, or you can get them in at 6 months?
6 months.
Yeah, perfect. Okay,
it's essentially the same. It's an incisional gastropexy effectively, although some papers actually just suture it, but we're still making a decision just like you would do in an open surgery. And then it's the suture with the V-lock suture with the hooks on it. So it's barbed suture.
I was just about to ask you. So we like the barbed suture now.
That's what we're using. Yeah.
Okay. Perfect. Yep. But you can use that. That doesn't have to be laparoscopic. You can just use that anyway, can't you?
Oh, you can. It's quicker.
Yeah.
In the laparoscopic version, the needle is passed between the jaws of a piece of kit that just allows you to just. It actually is magnetic and it goes between. As you close the jaws, it transfers to the jaw, so it pulls through, so you can suture like that. So that's sort of slightly different, but V-lock exists just as a suture you can use. It's very quick, don't have to tie anything.
Wow! But so
you pass the needle through a loop which is ready made in the V-lock, and that's your starting point. And then you just can take bites.
Oh, and then there's actual barbs on it that.
Yes.
And so what's the purpose of them, though?
So they stop the material slipping.
Right.
Once
Okay.
it's
So
gone through.
it's grabbing each time.
Every time I take a bite, the little barbs take a bite of the sutures.
That's
the
amazing.
tissue as well. So it allows you to do entirely laparoscopic gastropexy. So you've got a 10 millimeter, because you need the suture passer is a 10 millimeter trocar. And then you've got the cameras and one of the ports. There's 3 ports. So
Wow.
it's a little bit fiddly, but it's very nice for the dogs, and they wake up really comfortably.
Yeah. Oh, they would do. Yeah, definitely. And our success rate is the same as amazing.
Yeah, yes.
Amazing.
So, yeah, that's. I think that it makes the decision easier. Because as I said, I think desexing, it gets all tied in together, and then there's like a reticence to take that route. Because I think the message that maybe large breed desexing is probably something to discuss is out there amongst the pet owning public now, I think.
No, I think it is. Yeah, I think it is definitely. So then we're doing our lap pexies at the moment. Yeah, okay. So any of the vets out there looking want to come and watch you do some laps and see the barbed V-lock?
Yes. Welcome to. I mean, actually, you should record one, because, of course, it is a very eminently recordable
We should
thing,
actually,
isn't it?
we should record it. Easy to record, Tanya.
Yes. Well, thank you, Clara, for joining me on a very brief trip through GDV and what we currently are thinking with respect to that. Hope it's been helpful. As always, if anyone's got any questions maybe topics would be better than questions. Topics for future episodes, we'd really love to hear from you, and we'll try and cover anything. And if you do have questions, it would be good, actually. We could have a few of us around the table to cover a question session.
That'd be really fun.
So if you please do send some questions in, but they won't be replied to via email. If you send questions to us on our email address that comes up on the screen, wherever it is, we'll answer it in a session at some point.
Yeah.
That'd be cool.
Amazing.
Thank you for joining us again, and hopefully see you next time.
Bye.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.